we have a problem which we need to address, and that is that 26,000 women in the United States still die each year with what we consider the favorable type of breast cancer, hormone receptor-positive breast cancer. And the progression-free survival up till a couple of years ago for patients who presented with stage 4 metastatic breast cancer was only about a year, regardless of which of our anti-estrogen or rather aromatase inhibitor agents we used. With some advancements in the field, when a study which was led by SWOG investigators and was published in the New England Journal last year, put together the aromatase inhibitor anastrozole and the estrogen receptor degrading agent Fulvestrant was compared to anastrozole alone. The results turned out to be better. And then we finally figured out that using Fulvestrant at the optimal dose actually needs doubling the dose and giving it more frequently. So with that, now our progression-free survival for patients with stage 4 metastatic disease has increased significantly, but we are not quite there yet. There are also biological reasons why the anti-estrogen therapeutic agents alone do not work. And the second line from the bottom up suggests novel therapeutic intervention using the aromatase inhibitor exemestane together with Everolimus, which is an mTOR inhibitor. So we're now trying to combine the estrogen receptor blockage with blocking one of the potential resistance mechanisms, which is what Everolimus is supposed to do. And again, there was a very promising phase 3 randomized study published in the New England Journal just as recently as last year, suggesting that this approach will provide a significant increase in progression-free survival. And finally, there are preliminary data by Dr. Massawe and colleagues presented in an abstract form a couple of times already, suggesting that combining Fulvestrant plus the mTOR inhibitor Everolimus is an effective and feasible approach, and the toxicities are manageable. So here are the specific hypotheses for this particular proposal. That now that we know the optimal dose of Fulvestrant, that is 500 milligrams given Q2 weeks times 3 and then monthly, there is actually a significant progression-free survival in comparison to standard aromatase inhibitor. Just in parentheses, there's really not that much difference amongst using the 3 currently approved aromatase inhibitors, anastrozole, letrozole, and exemestane. So the data published from a study called FIRST, where Fulvestrant was used initially at the full proper dose, actually suggested that close to 2 years of progression-free survival could be accomplished by using the agent at the appropriate dose. As I mentioned, adding Everolimus to optimal dose Fulvestrant, the idea being that we now attack 2 potential mechanisms of resistance, is promising, and it's certainly worth testing. So that will represent the second arm of our proposed randomized study. So arm 1 will consist of patients receiving Fulvestrant at the optimal dose, and arm 2, as I'm going to show you in the next slide with the schema, will combine Fulvestrant and Everolimus. And then finally, we are trying to also assess whether putting together an aromatase inhibitor with Fulvestrant at the optimal dose plus the mTOR inhibitor Everolimus will increase the benefit even better. Now, again, I'm the clinician behind this, but I have 3 wonderful scientific collaborators who will entertain you with the idea of liquid biopsy and what can we get out of that in terms of analyzing circulating tumor cells. And this is really the main reason why we thought it would be a good time to present this concept. So this is the schema of the study. Arm 1 consists of injections of Fulvestrant at the optimal dose, and patients will be getting placebos for Everolimus and placebo. Arm 2 consists of Fulvestrant plus the mTOR inhibitor and placebo for anastrozole, and arm 3 will include all 3 agents. And the doses are depicted down there. You're all familiar now with the currently recommended optimal dose of Fulvestrant, and Everolimus is planned to be given at 10 milligrams, which is the standard dose, and anastrozole has a standard dose as well. I don't know why that says 5 milligrams. The standard dose is 1 milligram. I should have reread my slides, but that's the correct dosing. That kind of shows you we need feedback. All 4 of us looked at this, and 2 of us should know better, but it is a 1 milligram dose, so don't be shocked about that. The primary objective of this study is to improve progression-free survival by blocking both the estrogen receptor and the mTOR, the PI3K/AKT/mTOR pathway. And again, the comparison would be fulvestrant alone, fulvestrant, everolimus versus the three drugs together. And the secondary objectives include a variety of different things. Obviously, we need to look at overall survival, response rate, and clinical benefit rates, as well as assess the toxicities and compliance. As you know, patients who are getting either adjuvant or induction or metastatic therapies for breast cancer, and they use any of the oral agents we have in our repertoire, have a problem with compliance, not because patients can't take pills, but there are side effects. There are all kinds of interfering issues, including financial. So we want to make sure that what we plan to give is actually going to be delivered and the patients are willing to take it. And then finally, again, my scientific colleagues will entertain you with the specifics of circulating tumor cell assessment. Needless to say that, at least for the time being, circulating tumor cell analysis is a good way of prognosticating outcome in metastatic breast cancer patients, but we need to dig down deeper. So this is a truncated slide on the eligibility criteria. The first point to make, this is for first-line, either newly diagnosed or first-time and recurrent patients with ER-positive, HER2-negative, stage 4 metastatic disease. Patients have to have an ECOG performance status of 0 to 2. Either measurable or evaluable disease is allowed, and this will be one of the stratification factors. So no prior therapy for recurrent or newly diagnosed disease. Prior adjuvant anti-estrogen therapy is allowed as long as it has been completed more than 12 months prior to randomization. And there are some specific organ function issues which will need to be taken account because of the side effect profile of the agents. So less than upper limit, or less or equal than upper limit of normal ALT or AST is required unless patients have liver metastasis, when they can have up to 5 times abnormalities of ALT and AST. And as usual, no life-threatening metastatic disease or any other situations where, as physicians, we would like to use something more aggressive, such as chemotherapy.